people glow when they are taking radium. It's beautiful. They're like sparkle. So people started taking radium baths and drinking radium, and the jock straps made out of radium. It was huge. You look back in history. And then everybody started dying of cancer. Took a few years, everybody started dying of cancer. Are we doing the same thing with these things like massive NAD infusions to everybody?
Dr. Yurth got her medical degree from the University of Southern California Keck School of Medicine. She has 30 years as a practicing orthopedist, specializing in sports and spine medicine, working with the San Francisco 49ers and the San Francisco Ballet. She is the founder of Boulder Longevity Institute, an organization that brings us tomorrow's medicine today and that prioritizes education, pushing people out of the passenger seat and into the pilot seat of their own optimized health. She does this through her organization called Human Optimization Academy. Dr. Yurth is here today to bring us the cutting-edge health technologies you cannot get at your primary care physician's office.
Mitochondria are their own little beings. They're bacteria that are living in us. And remember, they also only inherit the genome from your mom. So they're much more vulnerable to not being as genetically sound. So mitochondria, and especially when you look at viruses like Epstein-Barr, they really destroy mitochondrial health. So I think you have to focus on mitochondria and things like.
Hi, my name is Chris Burris. I'm a longevity expert and the chief scientist at a lab focused on a longevity molecule. My primary focus is to help people live longer and better lives with science. Make sure to subscribe and share so you and your friends can live longer and better, so you and your friends can live beyond the norms.
Hi, and welcome to the next episode of the Live Beyond the Norms Health and Longevity podcast. I am once again so happy that I get to interview a medical doctor in this episode. I always love this opportunity. Today's medical doctor is Dr. Elizabeth Yurth, who is actually double board certified. Dr. Yurth got her medical degree from the University of Southern California Keck School of Medicine. She has 30 years as a practicing orthopedist, specializing in sports and spine medicine, working with the San Francisco 49ers and the San Francisco Ballet. I actually like the ballet more than the 49ers, but she is
I don't know,
the
they're pretty
founder.
neurotic, Chris.
She is the founder. Now half the audience is gone, right? She's the founder of Boulder Longevity Institute, an organization that brings us tomorrow's medicine today and that prioritizes education, which is why she is here with us today, pushing people out of the passenger seat and into the pilot seat of their own optimized health. She does this through her organization called Human Optimization Academy, which stands, it's the BLI Academy, which stands for the Boulder Longevity Institute Academy, but I think it also might be called Human Optimization
Academy. Right, that academy is actually called Human Optimization Academy, but you can actually find it online as BLI.Academy, but we actually call it Human Optimization Academy. It's sort of a separate entity from BLI, which is Boulder Longevity Institute, which is our actual clinical setting.
I love the Human Optimization Academy, right? Like, that makes perfect sense. I think many of us outsiders have the sense that we cannot rely on doctors to bring us the cutting edge health technologies. Dr. Yurth is here today to bring us the cutting edge health technologies you cannot get at your primary care physician's office. Dr. Yurth, thank you so much for joining us today.
Chris, thank you for having me.
So I'm excited to jump in, doing lots of research. Before we got started here, I mentioned that I don't think we're going to cover everything that we could possibly cover. Let's jump in. I'd like to get some background kind of information. You said you always wanted to be a doctor in one interview. How did your parents think about doctors? I think you talked about that a little bit. I'd love to hear that. And why did you choose to become a doctor? And do you remember the first case where you delivered a lot of value that probably gave you, great warm and fuzzies?
You know, it's funny because my parents were actually anti-doctor. I don't recall my parents ever taking us to doctors or going to doctors. And my dad particularly, my mom a little bit more mainstream, but my dad was, you can take care of anything yourself. I vividly remember him like as he got old, like these actinic keratoses on his skin, and he's got his little pocket knife and he's just picking, chiseling mosses, and I have a twin sister. I remember my twin sister once, we used to, she actually broke her leg when we were riding our bikes, and, it was like that, your are fine. I remember crawling around for like 2 days when we finally said, okay, we'll have to take her to the doctor. So, it was just sort of brought up in this household where you can fix yourself, right? For the most part. And my dad lived to be a very healthy 95-year-old. So I think growing up in this family where it was valued that you need to just take care of your health. I mean, my parents were working out before workouts were big. They were eating a healthy diet before eating healthy diets was big. I remember my mom was like, I remember watching her do Jack LaLanne. You're probably too young to remember Jack LaLanne, but he was in his little jumpsuit and he did these little exercises. And I remember watching as a little kid, watching my mom do that. So they were doing all this stuff like way early. So I think it was that realization then that, what, we can be our own doctor. But then I sort of thought, maybe I need to know a little bit more medicine than my dad does if I'm going to be my own doctor.
just a little bit more.
And so, so
a little bit more than
I kind of thought, I sort of had this destination of I wanted, since I was like a little kid, wanted to be a doctor. So, and I remember in high school, taking the bus and going and working at this senior center, this old age center, those places are so depressing, and these people who are just not able to care for themselves at all and having to learn that kind of compassion, how you care for those people. And I remember thinking, gosh, even then at that young age in high school, which was many moons ago now, that none of us wants to get to this state, right? None of us ever wants to get to this state. And yet this, and that's probably where they first kind of felt this value, was this compassion of, if you treat these people like humans, as opposed to just shoveling them away somewhere, can we actually help them, make them better? So I sort of had this kind of bend even from that realm to do that. So I think that all the way through high school. And it was funny, it was actually after I graduated from high school and I went to college. And then after college, I had gotten into medical school at University of Colorado because I was here in Boulder. And my boyfriend, now husband, but my boyfriend at the time was a couple years older, so he had moved to California. So I actually didn't go to med school. I actually moved out to California and just worked in a research lab. And I thought, I don't think I want to go to medical school anymore. I think I just want to do something else. And it really was a doctor I worked with in a research lab that said, no, you belong in medicine. You should go into medicine. So he kind of convinced me to go. And that's how I ended up at USC, that's where I was doing the research project. So that was so I took a few years off between college and medical school, and then finally went back to medical school at USC and sort of moved forward from there. And then ended up back in Boulder, Colorado after we're having kids, because I needed family around to help.
Yeah.
As you know, if you have little kids, family makes a big difference.
Makes a huge difference. My wife and I cried at the point when my mom was like, I'm not going to keep coming in on Fridays and take care of the kids, for our date night. We were like, do you need a toll pass? Right. What do we need to do? That was, yes, having family around is amazing.
Yeah, and my parents were integral in helping raise my kids. I mean, I took 2 weeks off work and was back at work, and my parents were integral in helping raise my kids. And I think it was good for both of them, right? It's probably why my parents lived very healthily into their 90s and why my kids have a respect for older people that other people might not have. I have 5 kids, so they really were there for, going through 5 kids. I do remember when I told my parents I was pregnant with my 5th, she's like, we're not doing this again.
He finally got cut off.
But actually they did. They still took care of him.
Yeah. It was a veiled threat. So it's pretty fascinating. I love the journeys of people, right? So you're going into that. You have kind of this impression. Ironically, from your dad, who was afraid or disinterested in the medical community, born out of that, you're like, well, I need to know more about that. Like, there's probably some greatness there. You start, and then you're just like, I don't really like it. And then it's so cool that you have this mentor that
somebody who kind of comes in, and gets to know you and says, really, you belong in this field, and you should go learn it. And then you can do whatever you want with it once you get there, but you should go do it. So.
Yeah, no, I think that's fantastic. I heard you mention a phrase, after 50, it's just patch, patch, patch. Talk about your transition to actual recovery and longevity, and I wonder how different did your practice need to become to be on the other side of this transition away from patch, patch, patch?
So that actually, I brought that up because it was actually a sign. So one of my colleagues, who was one of my mentors, my first orthopedic practice when I came back to Colorado, a guy named Dave Roeder, and he was just this beautiful man and beautiful doctor. And one of his patients had made him a crocheted or a needle-pointed sign that said, after 50, it's patch, patch, patch. That always hung on the wall of his office. And I thought to myself, that's actually what we do as orthopedic doctors, right? All we do is we patch somebody up, and then like they fall a little more apart, and we patch them up again, we fall apart, and then we maybe try and replace a part. And I really, and I did that for a long time, but with this kind of always underlying feeling like, God, am I really doing any good? Because every time you have these injuries, and I don't know if you've had orthopedic injuries, but I've had a lot, and you end up a little worse than you were, right? You never get quite back to where you were. And I thought, God, am I not doing the right thing for people? All I'm doing is patching them back together, sending them back out. They're never really normal again. It's a patch that doesn't look good. And so so really about now, 20 years ago, so I'd been in practice for quite some time at this point, I was like, maybe I can make people healthier. And then when we do these things to them, they'll actually get better. I won't just be patching them. I'll bring them back to where they were. So I started learning about how hormones and nutrition and the proper exercise and all those kinds of things. And so I tried to kind of combine that in my orthopedic practice. And you can imagine these 15-minute orthopedic appointments, and you're trying to tell people about diet and nutrition and exercise. And, let's look at your hormones and let's look at your vitamin D levels. And it didn't work great, and it didn't make my partners very happy because I would spend too much time with patients. And in fact, one of my partners, what was kind of the final straw of me leaving my orthopedic practice and just taking everything into my Bodo Longevity Institute, was one of my partners going to me, you need to understand, we don't do medicine, we do orthopedics. I was like, okay, probably not where we should be.
That's interesting because my mentor encouraged me to get back into medicine. That's
Right.
what I think I'm here for.
Yeah. So really I actually wore two hats for a long time. I actually opened Bodo Longevity Institute, and I would see patients all day long at my orthopedic practice, and then in the evening at my Longevity Institute, and try and really get people healthy at the Longevity Institute. And then really only about 4 years ago did we actually bring everything over to Bodo Longevity Institute. So we do all of our regenerative orthopedics here. I still have privileges at the surgery center, so we can do some things there. But mostly we're doing regenerative ortho here, as well as just a full spectrum of health-focused medicine or longevity medicine.
I remember you mentioned like orthopedic injuries, and I had one which was my calf would knot up, right? And I'm not sure that I've ever completely resolved it, but I remember my mom was working as a coder at an orthopedic surgery center, and she's like, "You should see this doctor. He's the one who's most likely to not recommend surgery right away."
Yeah, right.
And right. But the other doctors, like, you just had this sense you were going to go in and they were going to recommend surgery, and I think it is the better doctor that's willing to try. And you're trying to explain nutrition in 15 minutes. You can give them a piece of paper that they're never going to read.
Right.
Like
you can't do it, right? You got to go over labs with them. You have to be able to take time. You have to be able to know the person, know their life. You have to become not just a doctor, but a friend to your patients if you're really going to help heal them. And that's what we do. We spend hours with our patients. We spend a long time with our patients, and you get to know the patients. You get to know their families. You get to know their challenges, and then you can walk them through things and how they get better.
Was there, as you were kind of going through this transition, was there kind of, you probably maybe had experienced it early on, but a couple of cases or a case where like, wow, in the past I would have been forced to handle this very differently, and the outcome is probably so much better. Anything kind of popped to mind as I asked that?
Well, gosh, there's so much now because, I've completely changed how I look at orthopedics, and we can get into that, 'cause, a little bit more, but, no longer do I believe orthopedic injury, or arthritis, for instance, osteoarthritis, is a wear and tear disease. It is an inflammatory disease. It is not at all different from, your heart or your brain. Your heart shouldn't wear out. Your brain shouldn't wear out. Neither should your joints, even if you have an injury. So injuries are part of the, just like a virus might attack the heart and make your heart worse. But if you have everything appropriate, it can heal. The same thing's true. If I have an orthopedic injury and my genetics are right, and I take care of it right, I block the right anti-inflammatory things at the right pro-inflammatory cytokines at the right time, I can get this joint back to normal. So once my understanding of orthopedics as a disease and not just wear and tear, I completely changed. It was a paradigm shift in how I treat a joint, right? So if you came to me, 30 years ago with a meniscal tear in your knee, what we would do is maybe put a little steroid in it, right? Which actually would make it worse, but made you feel better for a short time. And then we'd send you to physical therapy for a while, and you'd be like, okay, I'm not great. And then suddenly we'd recommend going and debriding it. So we'd clean it up. We'd, trim off the torn edge of meniscus, and we'd smooth off the cartilage, and it will look much prettier to us. And I liken that to now if I sent if a patient came to me with dementia and I said, let's just go trim out the bad parts of your brain, it's all going to be good. That's exactly what we're doing to the joints. And it's why just scoping and debriding a meniscal tear in every other country has been banned. They do not allow it. It's the number one orthopedic surgery here. You know why? Probably money. And because people want something done, they're in pain, they want something done. So like, okay, the doc's like, oh, they'll scope it, it'll all be better. It's better for about 2 months, and then you start to rapidly degrade the joint and rapidly progress it to needing a total joint. So yes, that's all we would do, right? You do a little scope, that might last you a year, and then you end up going downhill and you do a little more PT and a little more steroids, and then you replace the joint. So now my whole process is much different. I see those injuries as an inflammatory disease process. How do I change the outcome of the injury by treating it as a disease and not as a mechanical force, not as a mechanical injury? So it's a complete paradigm shift. And the people we get better now is substantially more than I could ever get better with my old traditional medicine.
It sounds like I had the pleasure of interviewing Dr. Gundry, and his journey sounds very similar, where he's doing heart surgery and he's got this really tough case. The really tough case kind of heals itself through nutrition and supplementation, and for a period of time he just applied it after he had done surgeries, and then at some point the light goes off, which is a painful light, right? You've got a successful, lucrative career as a heart surgeon, right? And as in orthopedics, and you're like, but I want to shift this, so I'm fixing the problem before I even go and do the surgery or do whatever procedures I would have done in the past. Sounds
exactly.
Like
and you know what? The heart and the joint thing is actually much more related than you think, because if you have joint disease, you have about a 50% higher risk of having cardiac disease. And it has nothing to do with decreasing your exercise. So even if you kept your exercise up, it has nothing to do with that. It has to do with that the same inflammatory cytokines like interleukin-1 beta are involved in joint destruction and heart destruction. So they're very similar diseases. So he's taking that same approach that, we'll go in there, we'll stent it, and we'll do whatever. But the problem is you've got to treat the inflammatory process, and the exact same thing as the joints, and they're exactly the same pathologies, and the degradation is the same. So, it's a very good parallel, because honestly, it is the same disease, just in two different organs.
Yeah, different. Well, and I think some of the stuff that he is pointing out, and so many people that I've been interviewing are pointing out, you've got this leaky gut situation where once it gets through your gut lining and it's not supposed to be there, it looks like different things, right, to your body, different bodies, right? So this one looks like a heart cell, so I'm going to attack the heart. This one looks like whatever, meniscus or whatever. It's just fascinating to keep interviewing people with very different, incredible expertise, and it keeps folding back to this very similar thing. So you said in one interview, and I kind of touched on it in the intro, that you can't rely on a doctor to bring you the cutting edge technology. You're classically trained, you're double board certified. Why doesn't the classic, and we've touched on it a little bit, but why doesn't the classic doctor bring us cutting edge technologies? I think everybody who goes to their primary care or their orthopedic surgeon is like, this person has the most cutting edge. What's the disconnect?
There's a lot of reasons. It's actually been really well researched. And I think number one, when you're so busy on your treadmill, it's really hard to back off the treadmill and just take the time to learn that maybe there's a better way of doing things, right? Your treadmill's going, you've got to keep up, you've got, you're making good money, and you just have to stay on that treadmill, right? As soon as you step off, you feel like, oh my gosh, financially, and now I'm destitute, I've paid all these things. So there's a big unfortunate that when you're on a treadmill, trying to just keep up, trying to take any time to learn anything new seems like an outrageous adventure that you can't do. There's also a big piece of, let's say you just spent the past 4 years of your life building this beautiful house. It is, in your mind, the perfect house. Everything's to your taste. And now I walk in, I go, wow, I would have done this different and this different. This would have been a lot better this way. Like, you don't want to hear that. Like, the last thing you want to hear, right? The last thing you want to hear is that everything you've been doing, that you spent all these years of training, is actually not right. And it takes a lot of swallowing your pride and a little bit of, saying to your patients, listen, I hate to turn around, but you have to be able to admit you're wrong. And doctors are not great at admitting they're wrong. So, and even now, I mean, you know how fast our world is changing, right? Every year, something we thought was good turns out to be bad, and something we thought was bad turns out to be good, and we don't know, and unless we keep up. So I'm constantly saying to my patients, listen, this is what I know today. The reason you'll keep seeing me is because I will know something different in a year and maybe even a month the way information's unfolding. So I think that there's a big piece to, not really, it's a little bit like la la la. I don't want to hear this stuff because it's going to mean that everything I've actually done was not the right thing and maybe actually adverse to patients. So that's tough. I think that's also, keeping up with scientific research is really hard. But even if you take time to read, you're sort of spoon-fed. If you think about the articles that are sort of come to you, they're sort of spoon-fed to support what your beliefs are. And so to try and go, so I spend a lot of time when I'm researching trying to disprove my beliefs to see if I can actually disprove them. So if I'm researching, I actually look for things that disprove what I think is right. And if I can find enough research to support that I'm wrong, okay, so I don't go looking for the research that supports my belief. I actually go for the research that doesn't support my belief. And because you're going to always look for articles, and you can find any article you want saying anything you want. You also have to, when you're reading an article, it is, and you know this, when you're a researcher, it is so hard to read research because it has so much bias to it. And 80% of research is published as positive research for something. It doesn't show negative results. And a lot of it has an underlying incentive that you don't even know about. And so you have to be very, very careful about where the research is coming from, who it's coming from, and is it truly good data, even if it's coming from a reliable source? Is it truly a well-done research? Really, about 1 out of every 50 research papers that I read are actually really good research. And that's why it's so confusing to figure out diet, right? You read, you should be a vegan, you should be a carnivore. And you read these articles, and it's very hard because none of them are particularly great articles. So I think that there's, that finding good research, the conflicting information that's out there makes it really hard. And then the last piece is just incentives. I mean, if you go to my old partner, total joint guy, he has a pretty damn big incentive to put a total joint in you. And I think people don't even realize the incentives that are paid to doctors to actually to use certain equipment. Right. So a lot of these doctors, even, they become consultants to these businesses. So they're using a certain type of total joint, and they won't admit that they're being paid for it, but they're being paid as a consultant. Being paid as a consultant means I'm going to use your product. So I'm giving up, in some cases, $100,000 a year income as a consultant just to put a certain product in you and do a certain surgery in you. So there's a lot of money you're leaving behind when you step off that. And like you said with Dr. Gundry, I mean, I walked away from a very profitable surgery center. Things like that because so you have to be willing to say, okay, I'm not going to make as much money, but I'm hopefully doing the right thing for people.
I think as more money comes in, that gets to be a harder decision.
Harder decision, right? Yeah, sure, exactly.
It is just, in fact, harder. So it's interesting. You're like, the articles that are getting thrown at them are really kind of confirmation bias, right? Like they're just, and they're going to read it. I love that you actually kind of dig in and look for things that are counter your current beliefs. Like that's where you're going to find the measures. I've actually had interviews with people who are not interested in my product. I'm like, I actually want to have conversations with you because that actually makes me more balanced.
Yeah. If you don't believe my product, tell me why, right? Tell me why this is a bad product. I love being challenged. I love when my patients challenge me. And they say, well, my doctor said I shouldn't take this, hormone. I'm like, okay, can you show me the data your doctor showed you, right? And I always load them. I go, here is 10 papers. I want you to take these back to your doctor, have them read it, and then give me the counter papers. And and the doctors never do. So it really is. You want people to challenge you. That's you want to and there's certainly people who have changed my mind on things, right? They're valid.
And I think, the fact that they're not going to read the papers, that goes to, I think I've even heard people talking about, you're supposed to do continuing education, right, to maintain your board certification. And, some of these continuing educations are a video playing in the background while you're eating lunch, right? Like they don't even have to be really that involved. And you're going, 15 minutes to 15 minutes, like you're really on this. I don't think sometimes people don't realize they probably get a sense when they're at the doctor, like things are moving really fast, right? That there is this hamster wheel, and to like slow down. It made me think you spend more time with your patients now. How's your stress level since you kind of walked into a different approach? It has to be better, I imagine.
I think Yeah, that's a tough say because I have much more complex patients now, right? So I have certainly some patients, especially since the era of COVID. You know, patients are much more complex. You have a lot more serious. I'm treating a lot more serious disease people that challenge me and make me sad if I can't get them better. Versus seeing these people where you have these 15 minutes. I scope a knee. I stick some steroid in it. Blah blah. There's a little bit. It's rote, right? It's a very rote practice. And yeah, as much as you're on that hamster wheel, you kind of know this is what I'm going to do with everything. This is my protocol. That's what everybody does, and that's what I'm going to do. And now I sit down sometimes trying to figure out a complex patient for 2 hours, trying to figure out what the heck do I do with this patient? Why are they not getting better? And that's stressful to me. I feel really, defeated when I can't get somebody better. And we have so many complex diseases now, the autoimmune diseases that are exploding, the cancers that are exploding. So I would say my stress level is different. It's, I'm much happier. I won't say my stress level, and part of that is sort of self-inflicted. My husband always tells me, you just got to put work away sometimes. And I'm not very good at doing that. So, I think that part of that's me. I'm just sort of that's my personality, is to be stressed.
It sounds like it's born out of compassion, right? Which is, I think there's good data on if you see it as good stress or just bad stress, it actually has a totally different impact.
Yeah, that's true.
You.
Right. Yeah.
And this is good stress trying to help somebody.
But when you're treating somebody who has like a really bad disease and they're coming to you as their last hope, you always feel really sad, and when you can't help them. So
I mean, you feel sad coming in the door because, the system has already failed you to the point that you're walking in my door. And then let's roll up our sleeves and do the best we can.
Right.
You talked about and this wasn't kind of in my initial questions that I sent to you, but I think it's probably going to be a really interesting answer. You talk about this kind of autoimmune explosion, right? And so you're dealing with a lot of them, and a lot of the cases you're dealing with, I imagine, don't cause this stress, right? Because they're probably fairly straightforward. What would you say top 3 or whatever things are causing this autoimmune explosion, and obviously what might we do to kind of solve that if we're experiencing something along those lines?
You certainly have to blame toxins as being in there as a big player, right? That our food is, you can't get away from Roundup. Glyphosates are in everything we eat. I measure glyphosate levels in my patients. There's 99% of people have glyphosates, measurable glyphosate levels. Even if you're eating purely organic food that you grew in your own garden, because the rainwater is going to wash down from somebody who's not using, who sprayed Roundup on their lawn and got to you. So it's everywhere, so you can use things like humic acid, fulvic acid to try and help that. But that's going to create this chronic immune stress. And then you add to, with that we're just living in this toxic world. I mean, we've all read the microplastic stuff now, right? That, geez, there's microplastics found in every part of your body, from your brain to your sex organs. Frightening. And how do you get away from it, right? I just read some article, boil all your water. I'm like, okay, I'm not going to boil all my water. I'm just not going to, I can't do that.
And so that's not the only source. That's probably not the only source.
It's not the only source, exactly. It's like, so we have microplastics and we have all these toxins that we are not, I don't care, how clean you live, you are not going to get away from. So those are really challenging to our immune system. So what we have to do is make our immune systems healthier. And then you look at viruses where, COVID was certainly a big player here, but we had chronic fatigue syndrome before COVID. And, the long COVIDers are really not that much different from the Epstein-Barr virus people who had long COVID. We just told all the Epstein-Barr virus people they were crazy. Well, now we realize maybe they weren't because long COVIDers came around and had very similar disease. So we know it's probably more of a mitochondrial disease. So I think the explosion of viruses in these already challenged immune systems is just too much. And so our immune systems get very overreactive, and they're trying to keep up with keeping this virus at bay and keeping this toxin, detoxing these different toxins. And then we have the added that life is just, I think, more stressful. People aren't sleeping well. People are not in nice outdoor environments very much. We're not getting out as much and doing things. So there's a lot of stressors to our immune system, and mycotoxins, molds that are everywhere. So, like I said, you can't get away from them. So our best we can do is really try our hardest to support our immune systems as much as possible, because I mean, you probably know with even your product, which is really helpful in some of these autoimmune things, right? Is that if we get our immune system as healthy as possible, at least we should be able to face some of these challenges. Maybe if 8 of them come at once, we can't, but the hope is, at least for most of us, we can.
Hey, super quick break from the podcast. Hopefully you're loving it. This is a way you can support the podcast and take advantage of a great offer. We're offering 50% off of one of our MCT bottles. MCT is an amazing oil. Add the ESS60 molecule to it. It's even more amazing. All you got to do is leave a review on iTunes, send us a notification that you've left that review. We'll get you a coupon code that'll get you 50% off of our MCT oil and free shipping. Back to the podcast.
I have 100 questions about toxins, but I want to keep things moving. So you told the story on the Smarter Not Harder podcast of Elmiron, I think, if I'm saying that right, something that you've been injecting for, I think, knee and joint support. But tell that story, because I thought it was fascinating how you kind of encountered it. It was already kind of in the medical guidelines. I think it's a really interesting story, highlighting the kind of efforts that you really need to be going through in order to be presenting, cutting edge technologies.
Yeah, so first of all, we don't use Elmiron, but Elmiron is pentosan polysulfate. It's the oral form of pentosan polysulfate, and it's actually at a quite high dose. It's like 500 milligrams. So we use what's called injectable pentosan polysulfate, which has another name called xylitol. And what I do a lot of is 2 things. When I'm trying to treat a disease, number one, I go back and I look at the pathways that are messed up in that disease, right? So in osteoarthritis, there's very high neural growth factors, there's very high interleukin-1 beta, there's very high TNF-alpha, these inflammatory cytokines. So now I go, okay, what is out there that potentially I have or somebody else has that might work in this realm? One of the best places to go look is other countries, because other countries lots of times have access to things much earlier than we do, simply because the process to get something through our FDA system can take about 17 years. And in other countries, if a product is already deemed safe and effective, it can move much faster through that. So I always start looking through other countries' data. And what popped up about 2019 was a drug from Australia. So it was made by a company called Paradigm Pharmaceuticals in Australia. And Paradigm does one of my favorite things, which is looks for repurposing of drugs, which means take a drug that's already out there, widely available, widely used, already considered safe and effective, but for a different disease. So what Paradigm did is they looked at Elmiron, pentosan polysulfate, which was being used primarily as an oral drug for treating bladder inflammation. And it was a game changer. For people who had chronic bladder inflammation, chronic cystitis, it was a lifesaver to them. It was an incredible drug. But Paradigm said, wow, it's working on bladder inflammation by doing this. Where else would that be good? And they started actually looking at both as an antiviral agent, because it had some really interesting antiviral properties, but also for arthritis, because some of the same inflammatory cytokines were involved in these bladder inflammations in the joints. So taking a drug from a repurposed drug, as opposed to starting with a new drug. If you go to the FDA with your new drug and you're like, okay, I want to bring this to market, it's going to take you 17 years. Taking a repurposed drug can take as little as 3. At least in other countries. Here, maybe it takes a little bit longer. So they started repurposing Elmiron, and they found that if it was injected at a very small dose, so it's a considerably smaller dose than Elmiron orally for bladder inflammation, it worked remarkably well for treating arthritis of all types, even lumbar degenerative disc disease, all types of joint arthritis, because it worked on every aspect that has gone awry to make a joint arthritic and to destroy cartilage. It worked on improving neural growth factors, or actually stabilizing neural growth factors. It worked on reducing interleukin-1 beta and TNF-alpha and increasing what's called alpha-2 macroglobulin. So it worked on every aspect. So they started using it primarily in their rugby players and their football players, and they started putting all of them on it. And they found over the next few years, they reduced the need for total joint replacement by over 50%. It's actually improved even more than that now for the longer they've used the drugs. So they started using it. The follow-up studies that have been done, initially they thought, okay, it's really treating pain, but is it actually improving things? Well, the follow-up studies at a year showed not only were people considerably better in pain and they stayed better, but they had 30% improvement in cartilage joint space. So they actually were regenerating cartilage. So by blocking all these things, it allowed the body to bring in these healing factors. In animal models, you can actually completely regenerate a disc. So in a rabbit model using Elmeron or pentosan polysulfate injectable, you can actually completely regenerate a disc. So it's a really remarkable substance. And now it's almost 80 to 90% of joint replacements have not had to be done because of this drug, at least in other countries. It is in trials here in the U.S. So Paradigm has brought it to the U.S. It's in phase 3 trials now as the drug Xylosol. It will come to market, I think, probably in about 3 years. But we started using it in 2019 because, okay, it's being used in other countries. It's a safe, effective drug. Let's pull it in.
Yeah.
Now, about the same time, Elmeron started getting some bad press in the U.S. because it got linked to this bad eye, this bad maculopathy in the eye. It was only seen in a small number of people after they'd been 15 years on very high doses of Elmeron. So it was a dose-dependent response. So at 500 milligrams a day over a 15-year period. That's why it took so long. I mean, this drug's been being used since the 80s. They started seeing this maculopathy starting to occur about 2018, I believe. And it was small, less than 1 in 1,000 people, probably closer than 1 in 10,000 as you looked at the true numbers. So it was small, and it was very dose-dependent. It was people on the highest dose for the longest period of time that had it. Now, 2 things. Number 1, we don't know if that same thing would happen with injectable, but even if it does, it would take us about 80 to 90 years to hit the dose-dependent response of whatever caused that. Now, as a person who's been on this drug now for about 4 years myself, because I have end-stage arthritis in my knees. I've torn my ACLs 4 times. I have horrible arthritis in my knees, but I am pain-free, completely functional. I had knees that locked every time I sat down, completely functional with this drug. I will be fine if 80, 90 years, and by then we'll have some eye replacements anyway, won't matter. So, that I developed because it's been a life-changing, and it's been life-changing to a lot of our patients too, with both back pain and joint pain. It will come to market just for knee pain because when you work with the FDA, you have to pick one sort of use. So they went with knee arthritis. But it will definitely get approval. I don't know what insurance will do with it, but it's an injection that you give yourself, not into the joint. You don't really want to inject this into the joint because it's a weak blood thinner, so it can cause a little hemarthrosis or blood in the joint. But you do it as a little sub-Q injections. We just have people grab a little fat, do a little sub-Q injection twice a week. Its biggest side effect is it's a weak blood thinner, which in general is a good thing.
Like a baby aspirin.
Like a baby aspirin, right. So in general, it's a good thing to have a little bit of a weak blood thinner on board. But in some people, they'll get some bruising. If they're already on blood thinning medications, and sometimes they'll get a little bit more bruising. It's not a contraindication even if you're on blood thinning medications. So that's the biggest thing. Sometimes some site reactions you'll get from it. But other than that, it's been, again, now we're 6 years into its use in Australia. And they've magnified it. They're doing a big study now with NFL football players here in the U.S., actually ex-NFL football players. I mean, this drug is, the number of our patients who are like, oh my God, you have changed my life with this simple drug is amazing. So again, this is the understanding of this is an inflammatory disease, right? That's why if I treat the inflammatory component with a drug, as opposed to scoping it and trying to trim out the bad parts of the joint, I'm going to be able to get these people better. Now, as time's gone on, we've found all these other incredible things because as we've learned, as you look at the pathways that this drug affects, like dropping something called nuclear factor kappa beta, it's a very potent antiviral agent. So better than almost anything for herpes viruses, COVID viruses, EBV. So it's a really potent antiviral agent. It's also really good for a gut given orally. Now, so when we give it orally, instead of giving 500 milligrams, we give a 25 milligram dose. We because this drug's approved, we can have a compounding pharmacist do anything we want with it. We can say, okay, make me a 25 milligram oral capsule. So you can use it as a nasal spray for people who have allergies. It's a pretty impressive drug, and we use it for all sorts of purposes now beyond just its arthritis purpose. It's one of the best prebiotics that exists at a low dose, so it really helps restore gut microbiome. It's very anti-inflammatory to the gut as well, just like it is to the bladder. So this drug, I give whole lectures on this one drug because you can pull it in for so many uses. It's been a really life changer in COVID, these long COVID cases, because we know that there's a lot of times there's still some virus remaining, so we want to treat that. We'll get the antiviral properties with this, but also one of the big problems with long COVID is the microclotting. And so this actually, by being a weak blood thinner, helps with the microclotting, so you can actually avoid the microclots that are creating a lot of the ongoing problems that people have after COVID. And so we'll start this early on, lots of times in COVID patients who are starting to not healing well, to prevent some of the long-term consequences of it. It's a cool drug.
What an amazing story, and it's kind of, you're off-label prescribing it, right? I think that's kind of the
Exactly,
terminology.
right. It's an off-label use of a drug, and that's one of the things I love to do. Number one, go to other countries. Let's see what other countries are doing that we aren't. Right, like cerebral lysin. Cerebral lysin is a peptide widely used in Asia and Austria for brain injuries, stroke. If you IV infuse it right away, their results are dramatically better than if you have a stroke here in the U.S. Dramatically. Been used for 25 years. Company Everpharma makes it. 25 years in Asia. That's if you go to the hospital with a stroke, first thing I can do is run this IV. Not available here. And the reason is because it's a conglomerate of a whole bunch of neural peptides. To get it approved in the U.S., they would have to go through FDA approval for every one of the neural peptides. So it's never going to get approval in the U.S. It would take them 100 years. And they don't have any desire because Everpharma is very successful for it in the market that they're doing. So look at other countries and say, wow, this is working for them. Why wouldn't it work for us? And, and then we call Everpharma and we say, hey, can you get this to us, right? And you tell people this is not an FDA-approved drug here in the U.S., but it has a great safety profile in Asia and Austria. We're not that different, that probably our safety profile should be the same. And, and as long as people are aware, this can be markedly beneficial for people for dementia, for strokes, for, brain injuries. It's an amazing drug. So you go to other countries, let's see what they're doing. So I do that a lot. And then I do exactly what what Paradigm's doing. Let's repurpose drugs that are already available. So, I will deep dive the pathways that are distorted in a disease process for you. And then I can say, okay, here's where AI is going to help, right? I can say, okay, I need every drug you know of that affects these two pathways in the cell. And it spits me out a list, and I go, okay, well, that one's $20,000 a month. But this nice little supplement here is going to cost me $12 a month, and it actually has some effect on this pathway. So you can actually start repurposing things if you understand the pathways that are affected both by the disease and by the medication you're using. And it's fun. It's a really fun thing to do.
Yeah. I mean, it sounds amazing, right? Like, a lot of us biohackers and people kind of longevity enthusiasts are looking for a thing that solves one problem. And we get really excited when we find something that right away, as soon as it looks like it might solve it, great. Like that's exciting. And then you start, maybe injecting a peptide or something. You have this ability to go like, I think this will work on this pathway. And then you have the test cases that are able to kind of report back.
Right, and then you start trying it. Right.
Yeah.
It doesn't always work, but lots of times it does. So that's where that's why, you have to go back and relearn pathways. And, I went to medical school a long time ago. Half the pathways we didn't even get taught. They weren't even in existence. They probably still don't teach them. But, like the pentose polyphosphate pathway. And, so there's all these pathways that you have to go back to biochemistry and relearn so you understand the cell. It's hard. And it's why I think, unfortunately, functional medicine doctors who, are like, oh, we're treating the root cause. Well, they're not, because they're really not learning the cellular pathways that truly have gotten dysfunctional for root causes, right? I mean, if you look at the researchers, are the guys doing that. I mean, those are the guys who are looking at sort of the cell level and what pathways they gig out on that. But doctors don't. They don't want to go back and learn biochemistry. But you need to if you're going to really deep dive into understanding cell health and fixing the cell. And you fix the cell, you fix everything. You fix every disease that's going to happen to you.
Yeah, and that kind of leads me to a question. I think this is going to be a fun little question. Let's say you only had, for longevity, you only had two things that you could focus on: mitochondrial health or the gut microbiome. Which one would you focus on and why?
That's a tough question because they're both critically important. I don't think you can get anybody better until you fix the gut, right? The gut is too paradigm to the immune system. And, you have to get the gut healthy because 80% of our immune system comes from the gut. If I can't get my immune system healthy, it's really immune system failure that's going to be the link to most of the diseases. These autoimmune diseases we're seeing, the arthritis we're seeing is when I can't get my pro-inflammatory cytokines shut down and start my anti-inflammatory cytokines. That's all my immune confusion. Some of it's genetically based too, but there's a lot of immune dysfunction there. And if you don't have a healthy gut, you can't fix the immune system. So I think you always have to, if I'm not getting somebody better, the first place I go look is at the gut. And I don't like these tests that are looking at every single microbe, and because I had a patient who did I won't mention the name of a specific test, but a specific test that actually does that, right? And gives you this detailed list of every. It did it 3 days in a row, different names. Every one of them was different. So every one of them, because your gut micros is changing constantly. But you do want to look at phylums. You want to see that, the firmicutes, the bacteria. You want to look at all these different phylums and see that there's some balance in these phylums when you're looking at that. And you just want to look at inflammatory markers, and you look at digestive enzymes, and you look at make sure there's so many people who have parasites, and especially if you eat sushi. So you want to look at all that and fix all that and make sure that the inflammation's gone. They don't have a leaky gut, and or weird things. I just did this off topic, but my daughter, my oldest daughter, who's like 27, trying to get her hormones balanced, and she gets cystic acne and she just couldn't figure it out. And I'd done celiac testing on her. She didn't have celiac, so she's been kind of gluten light but not gluten free. Well, I actually did this full test on her looking at gluten. She actually, when she digests gluten, it turns into a gluteomorphone. It turns into a morphine that sits in the morphine receptor. So she actually, and it's what we call atypical or asymptomatic celiac disease, actually just completely disturbs the brain, just like if you were an opioid addict. It's like crazy, right? That this gluten becomes this opioid. So it's, these people, when you stop gluten, they feel like shit, just like stopping opioids on somebody, but it's actually critical for their brain and hormones and everything to start functioning again. You got to clear up the opioid receptors. So it's crazy stuff that can go on in the gut that sometimes it's hard to figure out. But, your next question is, mitochondria are my favorite thing, because look at the tissues that sort of die off the first for us. It's our brain, it's our heart, it's our muscles, right? Those are the most mitochondrial dense tissues. Those are the ones that need the most ATP. Those are the energy suck. Our brain uses more ATP than any organ in our body. So if we don't have healthy mitochondria, we're going to get dementia. And I can't say fixing the gut is always going to fix the mitochondria. Mitochondria are their own little beings, right? They're so cool. They're bacteria that are living in us. I love mitochondria. And remember, they also only inherit the genome from your mom. So they're much more vulnerable to not being as genetically sound, because you don't have 2 copies of genome in them. You only got them from your mom. So mitochondria, and especially when you look at viruses like COVID and Epstein-Barr, they really destroy mitochondrial health. So I think you have to focus on mitochondria, and things like carbon 60, urolithin A, like MitoQ, methylene blue, and then we use a lot of mitochondrial peptides in more serious cases like SS31 and MOD-SC and humanin. So mitochondria, when I can't get somebody better, next step is I go after mitochondria. But if you fix the mitochondria and you have an underlying fix the gut and help the immune system, So I don't think fixing the gut always fixes the mitochondria. Maybe helps, but it gets the immune system and the overall state of health in a place where now I can go after the mitochondria, fix the mitochondria, and hopefully get somebody better.
Yeah, that makes sense. I find it fascinating. I interviewed a Dr. Patel who's with MeScreen. I don't know if you've kind of investigated this technology, kind of fascinating. I love the concept behind it. And you're trying to figure out, well, one of the things that, as you were talking, that resonated with me, the mitochondria used to be bacteria, or still is, whatever we want to call it. And we're talking gut biome. Interestingly, everything that I just asked there, which are kind of the 2 most important things, are bacterial. They're not even, they're like not the human cells, they're the bacterial.
Because we have more bacterial genome than our own, right? Way more. So the bacteria are really controlling our lives a lot more than we control.
We need the shirt, ask me about my bacteria, because it's the only thing that matters. So let's talk a little bit about longevity. What do you think are things that we're missing when people are looking at longevity?
So I have a kind of a big beef here, and it's going to be, unfortunately, probably a little bit of disagreement and piss off some of your listeners. But one of the big things we tend to do,
this is like we're talking about, this is where kind of real education, real learning, real understanding comes in.
Here's where my big problem lies. So we look at things and people, and I'll use NAD as an example, right? Everybody's on this NAD bandwagon. Oh, we know NAD declines as we age. It's a fact. Pretty well proven. NAD declines as we age. So let's get NAD back in the system because it's absolutely essential to life. Yes, it's absolutely essential to life. So people are taking IV infusions of NAD and NMN and NR and all these precursors and not really looking at that this redox balance is really critical, and how much NAD you put into the system is number one, you don't know what the right amount is because you can't measure mitochondrial NAD. Some people are like, you can measure serum NAD, NADH ratios. It doesn't tell you what's going on in the cytoplasm, in the mitochondria. So you really don't know the answer to how much NAD you need. Now, the reason, you also need to understand why NAD is becoming depleted as we age. And it will deplete more if you have more fat cells, if you have more senescent cells, if you have cancer, because there's two enzymes that are degrading it, one called CD38 and one called NNMT. And NNMT might be the more critical of those because NNMT takes this extra niacin and it takes it down a different pathway to get rid of it, right? And so NNMT takes it and it does two things. It turns it down to be excreted as 4-pyridones and 2-pyridones. 2-pyridones aren't bad, 4-pyridones are bad. They're linked to cardiovascular disease and cancer. The other thing NNMT does is it takes SAMe and it takes a methyl group off SAMe, turns it into acetylcysteine homocysteine, and then homocysteine. So if I'm throwing NAD and I just keep loading my bucket with NAD and there's a big hole in my bucket, this NNMT, that's now turning it all into bad stuff. It's feeding this, bad dragon underneath the bucket. Then am I doing myself any good? And in fact, that's why when you look at, if you look at the people who have high NNMT levels, if you're old, if you're sick, if you have cancer, if you have obesity, you are going to have high NNMT levels. And in fact, one of the big areas of research going on right now is NNMT blockers. And you guys are all taking something that is raising NNMT levels. And cancer researchers are saying, we want a drug to block this, and people are taking a ton of NAD, which is just, if you look at NMT levels, they're going to be high because your body's like, I got too much NAD, I got to get rid of it. So now you're losing methylation, you're screwing up your methylation, you're raising homocysteine, you're increasing 4-pyridone, so you've increased the risk of every disease in the book. Now, maybe if you're a 20-year-old super healthy person and you just ran a marathon and you need a little extra NAD, that's fine. But I'm not going to say you should never take NAD or those precursors, but if you do, you better damn well block CD38 and NNMT. So we actually recommend, there's a supplement that just became available here in the U.S. It's called 1-MNA, 1-methyl-nicotinic acid. And 1-MNA actually is an NNMT blocker. So now I'm going to get my NAD stores back up, but in a much more physiologic way. It's going to block NNMT. I'm going to lower homocysteine levels. I'm going to restore my NAD levels. Plus, 1-MNA has all these other interesting good properties. It improves metabolism. It lowers cholesterol, lowers the lipids. It acts as a SERT activator. It actually acts like NAD. It's a rescue. And very interestingly, it is one of the pathways. NNMT makes 1-MNA and then goes into 4-pyridone. But 1-MNA, if you give it exogenously, does not raise 4-pyridone levels. Niacin does. 1-MNA does not. So you can get all the benefits of niacin without any of the downsides. You don't get the flush, you don't get the increased glucose, you don't get the liver dysfunction, and you don't get the increased NNMT levels. So 1-MNA is a very cool supplement and a much better thing. But it's this whole thought that, this is low, if I give more, all's going to be well. The body doesn't work that way. And the same thing's true of things that are bad, like ApoB. ApoB is bad, right? We all know it's linked to cardiovascular disease. So let's just push it as low as possible. No, because super low ApoB levels are actually shown to be bad for people dying of sepsis. People get bacterial infections. ApoB appears to have a very clear benefit in treating bacterial infections. So if I get my ApoB down 40 and I'm like, great, I'm going to have no cardiovascular disease. Yeah, but you're going to die of sepsis. So everything in the body has a balance. And we tend to forget that in longevity medicine. We think it's good, let's give more of it. It's bad, let's get rid of all of it. And really, homeostasis is so important. Like antioxidants, oxidative stress is a good thing. You want oxidative stress. If I'm slamming my body full of antioxidants all the time and I have now no oxidative stress, I'm all in this reductive state, that's not good either. Redox has to be balanced. So I really think doctors all these functional medicine doctors and these biohackers are not thinking about the homeostatic, really how smart your cell is. And we're actually screwing things up over the long term. And you have to look a lot deeper. You have to look at what are those pathways that you're actually affecting down the road, not just NAD is low, let's give more NAD. ApoB is too high, let's get rid of all of our ApoB. So I have a big beef with what we're doing here. I think we're actually creating. It took me back to when radium first came out. So radium got and you guys saw the movie. basically they discovered radium to paint watches' faces so the soldiers could see it, right? And then they're like, oh my God, people glow when they are taking radium. It's beautiful. They're like sparkle, and so people started taking radium baths and drinking radium, and their clothes were made out of, the jock straps made out of radium. It was huge. You look back in history, and then everybody started dying of cancer. Took a few years, everybody started dying of cancer. Are we doing the same thing with these things like, massive NAD infusions to everybody? I'm not sure we're not.
Yeah, and there's so many things, right?
There's so many things like that, exactly.
Decline as we age, and we're like, we should just prop it up, and maybe
not, right?
And I just had a conversation recently, about menopause and the hormones, and maybe that is a place where you should prop up the hormones. I mean, we could probably have a whole conversation about that also. But I've got to jump into our kind of regular wrap-up questions. I have like 8 more questions to ask, and maybe we can get
I talk too much, don't I?
No, like you share a lot of very valuable information. Like that's why I was so excited to jump into this conversation. But we can do this kind of rapid fire. Do you have a target age that you want to live to?
Yeah, I think that all of this kind of longevity people are like 120 seems to be that sort of target age where we think after that, probably you're going to start having to replace organs and things like that. And I will say, of course, I want my health span to be good, beyond my longevity. I don't want to be 120-year-old and decrepit. That's the goal of everybody. It's not lifespan, it's health span, right? When these people are like, why do you want to even live that long? You get bored. I said, God, I would love to see all the cool things that's going to come into existence, right? We're gonna live on, be able to go to Mars. We're going to be able to have shoes that we can jump 50 feet and cars that fly. I want to see all that,
Yeah.
I want to see all that happen. So I would hope that I can live nice and healthy into around 120, and maybe as technology gets better, we'll go longer than that. I suspect there's some point where I even look at my parents, who died in their 90s. There was a point where they just kind of got bored of living, right? I don't know. Do you get that way? I don't know. I mean, maybe at some point, I don't know when that would be, but maybe at some point you're just like, you know what? I'm just tired of being here. I want to move on. And I don't know, having not nowhere close to that at this stage of my game, but when I'm 120, will I be like, you know what? I don't even care if I go to the Mars anymore.
I think some of that just has to do with the fact that we currently kind of accept decrepitude as
right. You're not feeling well. Yeah, you don't feel as good. Yeah, I think
we've all been so sick. You're like, you know what? If people ever wish that they wanted to just not wake up, because I had it with scabies. Like I had scabies, and just the itching drove me crazy. And I was like, you know what? Maybe it wouldn't be that bad.
No, if you've ever had pain or things like that, or chronic pain, right? You can see why people get to that point, because every day you wake up and you're like, oh my God, I can't get through
more
this
pain.
Day, right?
So maybe if we're able to take that piece out of it, all of a sudden living a lot longer becomes so much more palatable.
A lot more fun, right? And exciting.
How long do you think humans can live?
I think that cutoff around 120 is probably where we're going to start seeing organ failure occur, no matter what we're doing. I really think you're just going to start, and you're going to have to start seeing that you can, do transplants of organs and things like that. I don't know that organs are going to be designed to go on forever. I think there's some point where you're just going to start getting organ loss, and it appears to be in that 120 age, at least if you sort of equate it from an animal studies. That's probably about that point. But I know. Do I think we can live forever like Brian Johnson does? I kind of don't. I don't think that we're going to be invincible. I think there's going to be some part of us that just is going to be really tough to sort of get us there. But I'll keep open minded to that. Maybe I'll be proven wrong.
You're one of the few who's the number for your how long you want to live and how long humans can live is the same. So I think that's great. I think that's telling, and I think that's going to happen more and more. What 2 to 3 protocols, habits, mindsets, let's call them shortcuts because everybody likes shortcuts, to longevity and a long health span can you share?
Can I say that the most neglected thing when people look at health span is socialization. And so people, we all know exercise is absolutely critical, particularly resistance exercise. Muscle is your currency of life. I listened to one of your podcasts with a guy who is, I can't remember who he was, but I just remember he was some kind of long distance runner, some kind of endurance runner, right? He was
Probably Anthony Kunkel, maybe.
Yeah, very thin, right? He was like,
Yeah.
he said he was like 6 feet and 143 pounds. I'm like, oh my God. So the classic endurance runner. Well, unfortunately, those people are really not designed for longevity. You want muscle. You want to resistance train. You want muscle. So you really do want to resistance train. So I think that, we'll all say exercise, and you may argue, whether it's aerobic exercise or resistance exercise. I still think muscle is one of our currencies to life, and you need to be lifting heavier weights and doing resistance exerercise and keeping your VO2 max up with some zone 2 type training. But so I think everybody says that. Everybody knows sleep is absolutely critical to longevity. But I think where everybody forgets is that we're living in a world that we're isolated more and more, right? We're in computer screens. I mean, I'm fortunate that I'm coming to an office every day with a lot of young people working with me, and and we have everybody from 30-year-olds to 70-year-olds working here, and so I get a lot of people interaction. But when I look at a lot of people anymore, even like my kids who have jobs, like my one son who, has a job where he's mostly working from home, right? He sees people most of the day, he's at a computer screen. Yeah. And socialization was a much bigger, China's studies showed that there was a significant, like over 20% improvement in lifespan based on how social you were. That's better than any drug that I can give you, any supplement that I can give you. It's just being social. And we really pay very little attention to that, especially as people get older, right? They're much more isolated. My parents were better because they had my kids and me, but a lot of older people are living by themselves, and the only person they see is maybe their spouse, and their spouse dies, and they're really not socialized anymore. Yeah. So we really need to pay a lot more attention to that. And how many of your doctors ask you, what is your social life like? How many people are you seeing? How often do you go out? Do you have friends? Do you have friends of all ages? You need some of the data shows that you want to be interacting with not just your own age group, but younger and older people as well, and maybe even children. So I think that we have to sort of focus on that. We don't, as doctors, we don't ask that question. We don't talk to people about how they can do that more, nor is the world designed to do that more. So I think that would be one of the big take homes I want everybody to put is you can do all this stuff you guys are doing. You can be Brian Johnson, and make sure you're getting your 8 hours of perfect sleep and eating your whatever perfect food. And yet, if you don't have this network of people, you're probably not going to do well. The data supports that your immune system will suffer, your lifespan will suffer. So I really think people need to focus on that.
Yeah, I like that. That's really good. And I jotted down socialization, resistance training, and sleep with kind of an emphasis on socialization. Dr. Yurth, how can people what are 1 to 2 things people get absolutely wrong about longevity? And I think you kind of touched on.
We kind of talked about that because I think that's that whole, if it's low, push it up. If we're young, it's high, and we're old, it's low, let's get it up. Not always, right? So I think it's that whole thinking homeostasis, not up and down. It's homeostasis.
Yeah.
You got a really smart body. You just have to kind of get it, so if you're fixing the pathways, you're going to get homeostasis as opposed to just dumping another supplement in.
Yeah. So maybe focusing on the numbers and not the pathways.
Right. That would be, you got to focus on the pathways that are involved and why the numbers are changing. And maybe the numbers changing isn't even a bad thing in some cases. There are some adaptations to age. Dan Goodenow, who wrote the book Breaking Alzheimer's, talks a lot to me about, some of the adaptations. You don't want your cells to be the same as they were when you were 20. He said you want them to have learned some new behaviors. Just like you're not the same person as you were when you were 20, and it's probably a good thing. You've learned a lot. He goes, your cells are not going to be the same. So when people are doing all this, this testing and saying they're getting their biologic age, is that, do I want my cell to be the same biologic age as it was when I was 20? Maybe not. Maybe there's some adaptations that are actually beneficial to me.
Yeah, maybe that's something we'll learn as kind of longevity-focused people. What is the ideal age? I have been told from a number of women that it's 29, but 29 is the exact age that they would all like to stop. Dr. Yurth, how can people contact you?
So for our Institute, Bodo Longevity Institute, they just go to bodolongevity.com. We have a great website there, which you can actually connect into. You can get more information about the programs. You can also connect into our other program, which is our Human Optimization Academy, which is our learning academy. We have a lot of physicians, but just, health coaches, physicians, people who want to learn. It's all learning through sort of scientific research. So I'm not involved with promoting any products or things like that. Nobody pays me to promote products. So it's all done through scientific research. And we do these Q&As that the questions people ask are incredible. It's so much fun because honestly, it's such challenging questions. So if you go to bli.academy, you can join Human Optimization Academy. You can also get there from motolongevity.com. But we have all sorts of, from high-level physicians to just lay people in that academy. And it's really fun. And then just follow me at Dr. Yurth on Instagram. I'm not a huge Instagram poster, but I try when something cool, a new cool research project comes up to try and post on that, or keep you alerted to where I'm lecturing. So if you want to come.
Very cool. And what in the near future are you excited about?
I think it's that we're starting to see a lot more collaboration in this field, as opposed to where it used to be a lot more competition, right? I belong to a network of docs. Dr. David Liu, who's an incredible human, started this network of longevity docs. It started out with like 5 of us, and now it's 150 international doctors that all do this kind of medicine. And I will tell you, this WhatsApp text chat group is there's 50 chats a day of people just talking about things and talking about cases and new things and new research. So, and that never existed before, where there's this collaboration between huge groups of doctors all throwing in input and learning from each other. It's not very usual in the field of medicine. Kudos to Dr. Liu for putting together this group and for all the people involved. So I love that we're starting to see this collaboration of people. I love that the podcasters are spreading this information, and it's not just in these isolated pieces. I love that we're entering more doubt into things. We're not just accepting things as much. And then I love what AI is allowing me to do in terms of like my passion, right? Oh, I want to affect the JAK-STAT pathway and lower NF-kappa beta. AI, give me everything you can think of that would do that.
Wow.
You could never do that before, right?
Yeah, I think the impact AI is going to have is, some people are worried that it's going to be everything, and then I'm hopeful that it's just going to be a lot of positive impact. All right, so you can find Dr. Yurth at boulderlongevity.com. Is that just
Correct.
Make sure I got that right? And then the academy is BLI.academy.
Right.
And then you can find her on Instagram at Dr. Yurth. Is it Dr. Yurth?
Yep. D-R-Y-U-R-T-H.
So not spelled out Dr. Yurth, and that's Y-U-R-T-H. Dr. Yurth, thank you so much for joining us today.
Thank you, Chris. I appreciate it.
I hope you enjoyed this episode of the Live Beyond the Norms podcast. Make sure to subscribe and follow. Also, make sure not to be that guy, the guy sharing this podcast with people who are not interested in living beyond the norms. If you would like to learn more about the ESS60 molecule, the molecule responsible for the single longest longevity experimental result on mammals in history, a full 90% extension of life, visit myvitalc.com. That's myvitalc as in carbon.com.